Let's keep going if we can. This is actually my slide, not Brian's, because you can see because
the
of the
colours.
The
only one.
And in this slide, we're going to actually ask some questions about this period. What we haven't talked about is the early relapse period, the dark blue period, which is not related to Picasso. The dark blue period of this particular slide is related to the first 3 months, this early relapse. Some people believe if you have super early relapse used on adjuvant pembrolizumab, you haven't had a good go at immune therapy. You need to have at least 6 months of immune therapy till you can define failure in kidney cancer. That's something which we've had a long chat about in some of our guidelines group, well, in some of them. And I'd like us to try and answer that question to start with. Brian?
I was just going to say, and this is not a trial, this is what would you do in practice?
Yeah.
So patient progresses in the first 3 months, would you give it yes, no? And then we're going to go through each of those periods, hopefully.
So this is the first 3 months. We're going to answer that question if we can. So would you keep going with the immune therapy if you progress in the first 3 months?
Wow.
I cannot believe this. 2 phase 3.
So we've got 33%, or more than that actually. Yeah, about 33. So if we could, we're going to call it 33. Oh no, it's going down all the time. About 30% of people would feel that if, I mean, my feeling is that 3 months is long enough for immune therapy to work, and I don't think we don't have much, I don't believe in pseudo-progression with Pembro. And I think if the cancer progresses during that time, I probably wouldn't keep going. Although I can see that being done. Brian, what do you think about that? Lawrence, I know what you think about it. What do you want, Lawrence? Why don't you grab a microphone? Give us your opinion. Because I know you feel strongly about it. Well, I know. I'm far away. Tell me what we talked about. Tell me what we talked about.
Yeah, so we had the chance to discuss that within the EAU guidelines. So the thing is, you want to make sure patients get properly exposed. And there's a thin line if you put that at 3 months or 6 months. Clearly 6 months means the patient has been fully exposed. But if this happened within the first 3 months, well, you'll never know that if the patient was actually properly treated. So my gut feeling is that I want at least 3 months. But there is that gray zone. We don't know if it's 3, 3 plus, 3 minus.
We talked about going to 6, didn't we? Giving like the first scan.
That was the decision we made, absolutely.
Yeah, do the first scan and then go to the second scan just to be sure. Progression on the second scan, call it a day. I think that's what we talked about there.
But to be clear, it's just all, you're just making it up.
Yes.
Yeah.
Yes.
That's awesome.
But I think there's a okay. Period 2, later relapse.
It's meant to be 3 to 6,
Choueiri.
I think.
So what Shilpa's just said is primary resistance. Petros, do you want to go to the mic? That would be cool. But she'll think what Shilpa just said was that actually the guideline, your guidelines say that defines primary progression and you shouldn't keep going. So there's a lack of consensus between Europe and the US, with Europe giving more drug than the US, which is unusual. Petros, you have a foot in both continents.
I have foot in both continents. I'm crossing the Atlantic here, but I would say that the SITC, right, Society of Immunotherapy for Cancer, has tried to address this question, and they have this, you can argue arbitrary but reasonable definition of primary resistance versus secondary resistance, and if I'm not mistaken, they use 6 months as an arbitrary threshold for primary or secondary. The second thing is, after someone stops checkpoint inhibition, there is some emerging data in melanoma that the occupancy of the receptor may last for a long time, 6 to 7 months. So the question is, should we have also that consideration of the treatment-free interval when we design the next trial, maybe in bladder cancer, mandate an IO-free interval, to have like a reasonable comparison in the experimental versus control arm.
Okay, so thank you, Petros. We're going to keep going. Period 2, we're going to vote again. This is relapse on therapy, not in the first 3 months. So this is patients relapsing during month 3 to month 12.
Yeah, I think the numbers got misaligned.
Completely.
Your slide.
That is my slide. The only one. Okay, so we're getting more consensus here. So everyone agrees that on therapy. Can we move to the next question, please? Oh.
People are still voting. Give them.
So actually 15% of people feel that even if you progress on immune therapy, and during that 3 to 12 month period, 1/8 of us believe that you should keep going with immune therapy. Can we move to the next slide, please? Or the next question. And so this question is the next question in that series. So this is, would you give PD-1-based immune therapy after adjuvant pembrolizumab in renal cancer and the relapse within 1 year of stopping? So it's that first year period. It's not the one that we agreed in the trial design. We said it would be more than a year. So it's, you've stopped immune therapy and then you're relapsing within that 12-month period. And it's about the same as actually progressing on therapy. It's still that 1/8 who think you should give it, but 85% people saying relapsing within the first year, you would not give it. And then can we move to the final question, please? And the final question is relapse after that year's period. So it's going up a bit, but here is 75-25%. So it's not a huge shift. Most people are not giving more immune therapy.
This is 80%,
Even
yes.
after a year.
Sorry, I've got completely wrong around.
Yes.
Oh, wow. Okay. So we've
That
got a
magical year cutoff.
Yeah, so that magic year cutoff makes a huge difference for us. We go from almost all of us
basically
not
flip.
giving it, and it flips completely the way around. What do you think about that, David?
Like I said, if you believe in the concept of PD-1 insufficiency, then just giving PD-1 alone might be useful to those patients who no longer have it on their immune cells at that point. But to me, it's got to be PD-1 plus something else. It's not, that enhances the immune response to the tumor. So whether there's a whole list of novel agents that can be combined with PD-1 that might make it work better, and those could be studied in that setting.